Does your uterus need pearls? Does it need steaming? Does it need herbs? Does it need charcoal cleanses? Believe me, these are things that exist out there. Does it need any kind of cleansing after your period?
The whole purpose of your period is like you're sloughing off tissue, so it's sort of detox. It's like self-detox, right? It's like getting rid of all those cells and lining in there. So that's like the perfect natural detoxification.
Welcome to HERology, the podcast from the Mount Sinai Health System, dedicated to advancing women's health through the lens of cutting-edge science and compassionate care. I'm your host for today, Dr. Lala, and our show is brought to you in part by the Carolyn Rowan Center for Women's Health and Wellness. Today we're discussing the most common myths about women's health. Sometimes as doctors, we have to regularly address misinformation, and we're here to set the record straight. I'm joined by people that I deeply admire, my regular co-hosts of this show, Dr. Joanne Stone and Dr. Anna Barbieri, two of Mount Sinai's most prominent and celebrated OBGYNs. Joanne and Anna, welcome to the show. I am so excited to be talking to you today. We are going to have some fun over the next 30 to 40 minutes. We're going to be debunking, hopefully, some myths we see on TikTok and Instagram, and other ones that are really kind of popularized in general. So, you all ready?
Yeah, I feel like we're like
ready
not
to
the
go.
Ghostbusters, we're the Mythbusters.
The
right now.
Mythbusters.
Yeah.
The TikTok busters.
There we go.
Let's do it.
There we go. Okay, so Anna, talk to me about seed cycling. Can I balance my hormones with seed cycling?
One of my favorite topics. Okay.
First of all, what is it?
Okay. So I don't know what people know what seed cycling is, but it's like a big TikTok thing, and there's companies forming around it. So seed cycling is the idea that you can regulate your hormones that drive your menstrual cycle by eating certain seeds, and specifically by eating flaxseed and pumpkin seeds in the follicular phase, which is the first 2 weeks of your cycle, so your period week and the week after, and then eating other seeds in the last 2 weeks. Okay, that does not work. Okay?
Like, who comes up with this stuff? I can't even
The
imagine.
theory is that certain seeds may be phytoestrogenic. So like flaxseed, for example, has lignans, omega-3s, those are great for you. It has some phytoestrogens. Okay, that is not going to drive your menstrual cycle. There's just not enough in there. So seed cycling, great idea to get some healthy nuts into your body. It is not going to solve your PCOS. It's not going to solve menstrual irregularities. It's not going to make you get pregnant if you want to get pregnant, or not make you get pregnant. So seed cycling, that's a no.
That's
for
a
me.
big no.
That's a big no
I was
for
going to
me.
say myth, or do we see some truth? You're going to call it a myth.
Myth.
Okay, I like it. So what about supplements? If someone's having a hot flash, can you say, listen, take some ashwagandha, you'll be much better?
All right. Well, ashwagandha, as you know, is one of my favorite supplements. Not necessarily for hot flashes, does not work for hot flashes. That's a bigger topic because we have to get a little bit more nuanced. You know, the typical answer is usually no, supplements don't work. And if you take them as a group, okay, for real hormonal issues, you don't want to assume that supplements are going to work. I do, as I'm an integrative physician also, I do think that some supplements have a greater body of evidence behind them. So, for example, something like Vitex that has some decent studies specifically about PMS and breast pain during a cycle. That's a potential there, but really, you know, again, something like fertility issues, severe PCOS, or really significant menopause complaints, there are better solutions for that than supplements.
And I think that also, like, creatine has some good data behind it for building muscle mass. So we talked in an earlier episode about the importance of building muscle, especially if you're on certain medications. And I think creatine is one of those supplements that has some good data behind it.
I agree with that.
I put it in my coffee every morning.
So do
you're gonna
I.
say
Yeah,
some
so do
truth
I.
to it.
Yeah.
Some
So
truth
do
to
I.
it. Seed cycling, myth.
Seed cycling, no.
Some supplements, maybe some truth.
Maybe some, not others.
Okay.
Complicated.
And last part of this myth busting, for fertility in particular. Any teas that we can take? Soy milk? Do you believe in any of these things that can boost your estrogen?
Red raspberry.
Red raspberry. Well, that's for labor, but yeah. But
Didn't make me go into labor.
Yeah, I mean, yeah, it doesn't really work so well. But no, I don't think there's really any good data behind these teas for boosting fertility. I mean, there are certain things we know that are really important to do for fertility, you know, being healthy, being at a good weight, you know, maybe some people advocate for gluten-free because it decreases inflammation. Depends on your underlying medical conditions, of course, like so much of this depends on that. But teas, I would cross my T and say, you know, definitely a
Fertility.
All
Fertility.
right.
Oh, that could be. That's going to become a brand pretty soon. Fertility.
All right, so we're calling
I'm sure
myth
it's out
number
there
one.
and taken. I don't know.
I love it. Okay, so Anna, this is much of your practice. Myth or some truth? Perimenopause begins at 50. Anything
that's-
younger than that, it's something else.
Okay, X on that. Okay, okay.
Are you going to get on the table?
Perimenopause for most people starts, it could start at 50, but it starts way before 50. Okay, I think we need to put an X in it and just say perimenopause lasts forever, or so it feels like it. But really, perimenopause typically will start late 30s, early to mid 40s for most women out there, and it will last several years, up to about a decade.
I mean, otherwise people would have been having like 50th birthday perimenopause parties. Like, it's going to be welcome to perimenopause, right? So
I don't know if anybody celebrates that.
So tell me just the distinction in your mind, perimenopause and menopause. Is menopause a day and perimenopause a decade?
Yeah, so great question. So let's go through some terminology here because it's important to speak that same language. So menopause, it's basically means the cessation of your menstrual cycle. And that is a day. It's the day your periods stop forever. You're not in menopause or you're not postmenopausal until a year has gone by from that time. Perimenopause is everything that is in between when your hormones change very regularly, cycle to cycle, and that day 1 year past that last menstrual period. So that can be a long time, and that's tricky, right? Because it's kind of like puberty. Like, there's some obvious signs of puberty, but sometimes, like, you know, if you're 11 and you're just not sleeping great and maybe you're like getting taller, like that's probably puberty, but you're not quite sure. So perimenopause is similar. A lot of women, when we first enter it, the signs are subtle. Maybe that period is not varied yet, but maybe we're waking up at 3 a.m. Maybe PMS is getting worse. That can certainly be very early perimenopause, but it's not super obvious. But yeah, so I would say like entry into it, late 30s to mid 40s for most women. Sometimes later, could be 50, usually earlier. And then the average age of entry into menopause, about 51, 52.
Okay. Joanne, can you get pregnant during perimenopause?
it's possible. I mean, certainly it's a time where there are a lot of hormonal changes, but, you're still, you may still be ovulating, so you can definitely still get pregnant during perimenopause. As you get older, of course, infertility rises, so by the time you hit your late 40s, less likely that you're going to, get pregnant spontaneously. But certainly, late 30s, early 40s, absolutely.
Okay, we are crushing these myths, people. Busting them, I should say. I like it. All right. Now, this is in this modern age where we can essentially have a test for everything. We're doing ultrasounds for so much, right? Based on our OB experience, but then even afterwards, cysts on the ovaries, fibroids in our uterus, polyps in the uterus and elsewhere. True or false, truth or myth, if it's on an ultrasound, it's got to be dangerous.
So I think I can take that one since I do ultrasounds so much of my life. So I think, in general, a myth, right? Because a lot of the findings that we see on ultrasound are totally benign, meaning that they're not of concern. So you can have a small cyst that's really small and it's clear, it's simple, it doesn't really mean anything. especially if you're pregnant, cyst commonly occurs after you ovulate. A cyst maybe when you're later in life that looks a little bit more complex might be a reason for concern. A lot of people talk about fibroids. Fibroids are growths of the muscle of the uterus. They look like little balls inside the uterus. Most of the time, there are no symptoms. They mean nothing. So not to worry. It's all over like TikTok, like they're horrible. It's like a crazy thing. You got to remove it, things like that. Now, for some people, rapid growth or the certain appearance of it might be concerning. Polyps in general, they could also be just an incidental finding, but there are other polyps that may be associated with bleeding after menopause, let's say, that might become an issue. So I would say, for the most part, definitely it's a myth that everything is abnormal, but, you have to put it in the context of really what you're looking at, the age of the person, the health, and what the actual findings are.
So maybe to that effect, transitioning past the OB space, when should you have a pelvic ultrasound in perimenopause, menopause in general? Do you have like sort of a cheat sheet for us, or would you say how much is too much?
Yeah, so you know that old saying, right? If you look, you shall find. So if you look, you shall find lots of things. The statistic on fibroids is something like 80% of women by the age of 45 have fibroids.
Wow.
That doesn't mean that we need to look for them in everybody or do something about them when we find them. So I really advocate for very rational use of technology and diagnostics. And typically we recommend something like pelvic ultrasound to identify an issue that is being investigated due to symptoms. So someone who has abnormal bleeding, too much bleeding, too frequent bleeding, you want to really do an ultrasound to figure out if there is a structural reason for that. There may not be a lot of the times because in perimenopause, that good friend, a lot of the bleeding abnormalities are driven by hormonal changes and not something that's growing in the uterus. Certainly for things like pelvic pain, sensation of pelvic pressure. Yes, we do ultrasounds to, again, look for structural abnormalities, ovarian cysts, and so on. And that's important. I think the question of, should we be doing ultrasound routinely as a screening method, let's say for ovarian cancer, right? Big deal because we don't have a good screening method for ovarian cancer. That actually has been looked at in terms of trying to get the data on this, and routine screening ultrasound in asymptomatic women does not work. It's not a good screening tool for ovarian cancer. So I'm really careful about kind of elective screening with these methods because, again, if you look, you shall find, and a lot of the times it doesn't mean so much. Everybody gets super anxious, then they start doing procedures and so on. But yes to diagnostics for symptoms that will give us a result that we can act on.
I mean, I agree with you with my medical hat, totally agree with you. But there's another piece of me that's like, okay, so as a gynecologist, you do a pelvic exam. So you're putting your hand in, you're feeling the uterus, you're feeling the ovaries. You might be doing rectal vaginal exam, which is really uncomfortable, where you can just do a vaginal ultrasound, see all the things that you're trying to feel, right? And you could see the ovaries and you could see the uterus and, assess its size much better than a pelvic exam, and especially in women maybe who are overweight where it's really hard to feel. So I don't know, there's part of me that's like, I think ultrasound, I mean, you're a cardiologist, right?
I'm like holding back here.
Exactly. How, you can listen with the stethoscope or you can do an echo and actually see what it is that you're trying to hear. So and I agree, listen, as somebody, that did an ultrasound and found some cysts, and now I have to get followed every year because I found the stupid cyst, and whatever. And then another person did an ultrasound, can see my pancreas and found a little cyst in my pancreas because they were just scanning my pancreas, So yes, you're gonna find something.
Slippery slope.
It is a slippery slope, but it's like
I hear you. I mean, I totally get that, and I get the conflict. We have people coming in all the time who get elective full-body MRIs, right? That's a thing. And on one part of me understands we can follow it every year because it's good to find something super early and take it out, and you can watch it grow and intervene. And then this other part of me is like, holy moly, we're going to be finding, I don't want to find a cyst in my brain. What do I'm going to lose sleep over that, and what can I do about it? So it's really, it's a very, there's some tension in this idea for me too.
Yeah.
So I would say, low threshold. Low threshold for doing imaging. I agree. I can see a lot more with an ultrasound than I can feel with my hands. But I'm not quite on board with just lots of imaging electively for everybody, every 6 months.
Okay. So I like that. I'll take that. So if it's on an ultrasound, it must be dangerous. We're going to call that a big myth.
Yes.
Okay, great. Joanne, this one's for you.
Okay.
And this one comes up so frequently, even in the cardiology world. You've got a woman who's pregnant, 3rd trimester, feeling big, but is a runner and misses running. Is it safe to exercise during pregnancy?
It's not only safe. It's
She's getting on the table, people.
I am. It's so good for you to exercise. There are plenty of studies out there that show that women who exercise during pregnancy have fewer pregnancy-related symptoms. They tend not to gain too much weight. They feel better about themselves, and they keep it going because, all of a sudden, you take home that newborn, and you got no time. Like, you're exhausted, you're sleepless, and you may not have the time to exercise like you had been. So exercise is key. It's crucial. Of course, in the setting, there could be certain conditions, if you're bleeding, if you just had a procedure, some medical conditions where you say, don't exercise. But for the most part, for a healthy pregnancy, you definitely should exercise.
Is there this is too much?
No.
Because I think that's where there's a lot of tension. Like, can I
people
go for
always
a
ask,
10-mile run?
Can I raise my heart rate
Right.
over
Yeah.
a certain,
It used to be thought that you could not raise your heart rate above 140. That's no longer thought to be the case. There was an article, it was like in the New York Times a few years ago, about a woman who ran the marathon 2 days before she delivered. She was totally
That's
ran a
right.
marathon.
I remember that.
So a lot of it is, I wouldn't suggest going from 0 to 100, right? But work yourself up, and do exercises that make you feel good, and it's good for your mind too, and
that's the key.
Yeah, when you're pregnant and you have you're
weighted
anxious.
vest in pregnancy?
Yeah. And would you say the
I
same?
don't know how that goes over your boobs, but
and same sort of recommendations no matter what trimester you're in?
yeah. In the first trimester, sometimes people they're just so nauseous, they can't eat, they're fatigued, they just can't muster it up, and so listen to your body in some ways.
Listen to your body.
Listen to your body.
I feel like we don't do that enough, right? We
Yeah.
just want someone to tell us what to do all the time.
Like TikTok. No.
Yeah. But I think that's really helpful. Okay, so we are busting myth number 4 that we indeed can exercise and in fact should exercise during pregnancy. So myth number 5, how about should you detox your uterus after your period? Talk to us.
Just kidding.
Seeds. No, I'm kidding. Does your uterus need pearls? Does it need steaming? Does it need herbs? Does it need charcoal cleanses? Believe me, these are things that exist out there. Does it need any kind of cleansing after your period?
I'm going to let Anna take this, but I will just say that the whole purpose of your period is you're sloughing off tissue. So it's sort of detox. It's like self-detox, right? It's like getting rid of all those cells and lining in there. So that's the perfect natural detoxification.
No. You don't need to detox. You do not need to detox your uterus. And I would go one step further. Attempt at detoxing your uterus. If you're putting garlic, people do this, but please don't do this. If you're putting garlic up there, sour cream up there, soap up there, they may actually do the opposite of detoxing the uterus because you can affect your vaginal microbiome and cause certain infections. So, yes, no to detoxing your uterus.
Okay. Busting another myth. So now, this one comes up a lot. IUDs. Okay. Can they travel in the bloodstream to, and I'm having a difficult time asking this question as a cardiologist, but this is a myth that's out there, to your heart, or even worse, to your brain?
Yeah, this one, I could not believe it, is like so insane. No, they cannot travel in your blood, make their way up to your heart or your brain or any.
You don't say.
Yeah, exactly. I mean, sometimes they can get dislodged, and sometimes they can, rarely go through the lining of the uterus and end up in the abdominal cavity.
Okay.
But that's unusual, and in the abdominal cavity, they're not going to be able to travel and get to your heart or your brain or any other place.
Just, taking it back and bringing some seriousness into it, because obviously myths exist because there is fear, right?
Yeah.
And while it can be kind of funny and sensationalized, there's also this underlying desire for us as physicians, clinicians, to dispel myths so that there is less fear, right? And because our patients deserve informed choices and not fear. So what exactly is the IUD? Where is it placed? And why do you think that there may be this concept that it could get dislodged potentially to another organ system? I mean, you kind of already touched on it a little bit.
Yeah, so an IUD, there are different types of IUDs. There are hormonal IUDs and then non-hormonal IUDs. They're mainly used for really excellent birth control, so prevent pregnancy from occurring. They're placed through the cervix into the uterus. Often an ultrasound actually is used to verify the location that it's placed properly, and there's really
indicated ultrasound. Yes,
ultrasound, really like good 3D imaging to see it, and you can actually even see the string coming outside the cervix. It's fascinating. But in some patients, let's say you go for checkup and your doctor does a speculum exam where they put the metal or plastic speculum in, they don't see the string anymore. Then you want to do an ultrasound to look, did it get dislodged? Is it maybe somehow going into the uterus itself, and very rarely would it go beyond the uterus into the abdominal cavity. But they're really good, and in fact, the hormonal one often people don't get periods on, so for people who have like heavy menstrual cycles, sometimes it's used for that so that they don't bleed so heavily, and in fact, many of them don't even get a period after several months of being on a hormonal IUD. So they can be really good, but they will not go to your brain.
Okay, and I won't see it on an echocardiogram.
No, you're not going to see it on an echo.
I would also say, putting my serious hat on, is some of these myths, like this IUD one, stem from the fact that lots of women don't know their own anatomy, and that there is still like some taboos and shame around the female anatomy, and like there should not be. Like these are body parts. Yes, your vagina and the uterus do not have open channels with your heart or your brain. I mean, that's from like 2,000 years ago, right? So we should move beyond that. But I think that's what sometimes is behind it. That's different than someone claiming that, let's say, their hormonal IUD is affecting them emotionally or causing side effects. Because I've heard that too, since we're talking about myths, how, oh, no, IUDs are just local and they won't cause side effects. And the reality is that there are some people that are sensitive even to the small amount of hormone that's technically released locally, but there are patients and women that have some systemic side effects, and that can happen.
I love what you said about, I think, this kind of overall shame that women tend to feel about their anatomy, to the point where literally you say vagina and they're like, oh, it's a body part. We all have it.
Wait, can I tell this quick story?
Please.
I'm going
I love your
digress.
Yeah.
Okay. So this was when my daughter, I have two daughters, and she must have been 4 or 5, and she was at preschool. And I was called. I'm like, what did I do again? Did I forget to, put underwear on her, which I have done also, right? No, they wanted to know why my daughter knew the word vagina.
Oh, wow.
Because they thought that this was an unusual thing and signified some sort of inappropriate exposure to media or, something. And I'm like, no, like this is what we call body parts in my house. Like we call them by their name.
Yeah.
So, yes.
I know. I mean, same thing. I have 2 daughters also, and I was so open, like growing up and calling. I mean, we used to play like having a baby and putting an epidural in and pushing it, stimulating a section. But one day, one of my daughters walked in. She must have been like 3, and says to my husband, "Are you going to put your penis in mommy's vagina and have a baby?" or something like that, like at 3. My husband was like dying.
The birds and the bees is supposed to be later.
Yes, that would get you a call from the preschool my daughter went to. Yeah.
Yeah, but it's true, and I love what you said. I feel like it is taboo, and we don't talk, like, when you have your period and you're 11, 12, 13, I feel like you're hiding it.
Yes,
you're embarrassed.
It's the worst.
It's the worst, and we need to normalize it,
You know where I see it too, just because, I mostly take care of women, probably mostly midlife and beyond. My much older patients, and I do think some of it is generational, when we use vaginal estrogen, that does require self-insertion. So you have to put in either this cream or this little tablet or this little sort of capsule vaginally. Some of my patients in their 70s will say, I just don't know where it goes. I'm afraid of putting it in the wrong place, because they just were taught to never touch, never explore, and like you really see that in practice. So anyway, just a call to
we talked a little bit
for
on a
awareness
previous,
and education.
Absolutely, we talked a little bit previously about self-compassion, whether it's midlife, whether it's adolescence, whether it's in our reproductive years or beyond, and I think that some of that body image, shame, weight-related preoccupation, it's all related. There's something to be, I mean, how amazing are we that we have the organs that we have, that we're able to do the things that we're able to do, whether you end up having children or not. So I love this conversation about that. Okay, so busting some more myths.
Let's do it.
Talk to me about this one. A pap smear is equal to an HPV test. Myth or truth? Tricky.
Sort of.
Tricky. Okay.
So currently, when somebody is going to have a pap smear, what typically is meant by that is having a test that screens for cervical cancer and precancerous changes on the cervix. And currently, the way that it's done most of the time, there's a little brush that goes on the cervix, which is the bottom part of the uterus. That's the part that's visible in the vagina. And that sample is used to analyze the cells themselves. So that's your classic pap smear. And is used to also run the HPV test, which will look for the presence of the virus called human papillomavirus, or HPV, in that sample. So they're kind of done as one thing, but they are 2 separate tests, actually. And the next phase of this test was actually just approved this past year. The sort of the collection of the sample for the purpose of screening for precancerous changes on the cervix will likely mostly rely on HPV analysis, but will be self-collected. So that's going to be a major game changer. And again, the test was just approved. It kind of looks like a kit that can be mailed to you.
And then you do it yourself, sort of like a Cologuard.
But you do need to know where to put it,
yes,
right?
Yes, exactly. Prerequisites. Yes.
And just to say that HPV, which is human papillomavirus, is thought, and there are different strains, or there are different subtypes, and some are much higher risk than others, but that's what is the virus that's thought to lead to cervical cancer and precancer cells. And that's why it's so important, we have HPV vaccine that, that people get from, I don't remember what the younger age is, maybe age 9.
It's approved from age 9, yeah.
9 and above. And it's for both men and women. So because
right.
guys can also get HPV as well. So really important.
So important. So I like that one because it's sort of related.
Yeah.
Okay. Let's talk a little bit about irregular periods. What do they mean? So irregular periods, do they always either equal PCOS or perimenopause, depending on your age range? Myth or truth?
Okay, the simple answer is no, they don't always equal that or the other.
Yeah. I mean,
Are you done?
I could go on for 3 hours, but
it also depends on, the circumstance, how old you are, other medical conditions. So, if you just had a baby, let's say, and you're in the postpartum period and, you're breastfeeding, you stop, and sometimes it takes a while for your period to regulate. So you can have irregular periods because of that. You could have irregular periods because you have PCOS. That's a possibility. So, but it doesn't mean that you have PCOS. Or, if you're in the perimenopause, right? You can have irregular periods. So maybe you get a period start spacing out to every 3 or 4 months. I mean, you're the expert, not me, but.
So it's a symptom rather than a hallmark of a disease state.
yes. So the way I think of irregular periods is how I explain it to my patients. So once someone has had a period, we know that the hardware, so kind of your anatomy at least, is there to result in a period. There are some very rare states where somebody may not ever get periods, and that's a whole other conversation. But once a woman has had a period, we know that the pipes are there to allow for a period to happen. So irregular periods could mean that periods are really far apart, or they occur at an irregular, maybe every 4 weeks here, but 8 weeks later, or that they happen closer together. The more common thing is going to be periods that are too spaced out or are really irregular. And that's going to be driven by hormones. So now you have to ask yourself, okay, if the issue is hormonal, how do we decipher what that hormonal reason is that's responsible for the period irregularity? You're going to have states that the two different categories are going to be a bucket of low estrogen states and a bucket of high estrogen states. So that's going to be your determining factor. PCOS that you mentioned, it is the most common reason for irregular periods in women of reproductive age. That's a high estrogen state where estrogen is made, but ovulation does not happen regularly, so that person is not getting a period. Low estrogen states are going to be, for example, a mom that's breastfeeding. In order to breastfeed, her prolactin needs to be up. Prolactin is going to suppress estrogen, no ovulation, no period. It's going to be that super thin athlete or a model whose body is simply not seeing enough energy production and fat storage for her to mount adequate estrogen production. Low estrogen, no ovulation, no period.
I feel like I need to be taking notes.
And
There's going to be tests after
I know,
this.
seriously.
Yes. And then perimenopause, this is fluctuating but declining estrogen. And then menopause, right? Low estrogen, no ovulation, no period. So that's kind of how I think of them.
Beautiful.
And there are some, thyroid states is going to be another thing that's going to screw up ovulation even in the presence of estrogen. So that's going to be on this side. So it helps to kind of have that framework because I think people can understand it a little bit better. And that's how we also know how to intervene by understanding what the initial reason is.
I love that. I think that's a super important lesson to take home. So myth-ish, right? So irregular periods may mean PCOS, but it doesn't always mean PCOS. So
Sorta.
Sorta. I like that. I'm going to get a little controversial as we come to the end here. Let's do it. What is the difference fundamentally between birth control pills, the hormones that are offered in birth control pills, and the hormones that are offered in menopause hormone therapy or hormone replacement therapy, which it used to be called? How would you explain that to me, let's say? And then we'll take it a little further and maybe make it a little more spicy in terms of where we stand now.
I'm going to turn it to the hormone queen over here.
I know my favorite
Yeah, it's your
questions.
favorite thing.
Okay. So, hormones in a birth control pill, they are going to be of two types. There's going to be typically either a pill that will have a combination of a estrogen and something called a progestin. Those are going to be synthetic analogs of human hormones, estrogen and progesterone, but they are not exactly that. So most pills will have, there are different types of estrogens, like ethinyl estradiol is going to be the most common ones, and there are different types of progestins. And the dose of these hormones in a birth control pill is high enough and potent enough to suppress a woman's hormonal cycle. That's how the pill works, right? The body sees these hormones and says, okay, that's plenty. I'm not going to make my own. Therefore, I'm going to stop ovulating because I'm responding to the signal like this, and therefore pregnancy does not occur. There's also other birth control pills that are not combination pills that will have a progestin only in them. The mechanism of action is a little bit different because that's not going to prevent ovulation all the time. It's going to rely on other contraceptive methods like thickening of cervical mucus and slowing down your fallopian tube so that egg doesn't travel as fast into the uterus. The hormones in menopause hormone therapy or MHT regimens can be sometimes similar, but will be at a much lower dose because they are not meant to suppress your normally functioning cycle. They are meant to just gently raise the levels of these sex hormones in your body. And they can be either similar in terms of estrogens and progestins, so not exactly the same on a chemical or molecular level as human hormones, or they can be the same as human hormones, and some people call that bioidentical. That's this controversial sort of name. I would say we have to agree when we talk about bioidentical hormones here, all I mean by that is these are the hormones in exactly the same molecular formula as what the human body makes. Typically, that's going to be estradiol and progesterone, but there are menopause hormone therapy regimens that will have non-bioidentical hormones. It's confusing, right?
You go, girl.
Okay. Anyway,
So
that's
myth,
the difference.
So the myth is that they're not the same, right?
Right,
So
that's
we're
the
breaking
bust.
that. Yeah, that's what we're busting, right?
They are not the same biochemically all the way, and their dose and potency is not the same either.
And that's an important distinction,
Yes.
I think, for all of us to kind of recognize.
And I'm glad you mentioned about the progesterone-only birth control pill because we have a lot of patients.
Yeah,
who
talk
are-
to us a little bit about that.
Yeah, so a lot of patients who are just had a baby who are postpartum, one thought is that estrogen can sometimes suppress lactation from occurring or may not have enough milk supply. So by giving the progesterone-only pill, I mean it's not as good as the one that contains the estrogen as well, but it is quite good. The combination of lactating, which suppresses you from ovulating, and the progesterone-only pill is commonly used. I mean, a lot of people think, once breastfeeding is really well established, it's fine to be on a regular birth control pill, but for some people who maybe are not lactating as well, it's a good option.
But, speaking of the birth control pill, like the big TikTok thing I don't know if it's on it because I'm actually not on TikTok,
I know,
but I
don't
just
have a
hear
TikTok
about it.
account either.
That there were all these videos of women, flushing their birth control pill down the toilet because of all these, side effects, and it ruined your fertility, all this stuff out there. Like, the reality is birth control pill is a tool. Like, it's a tool. It's great to have it if you need it. It can be a wonderful tool for contraception. It can be a medical tool for control of terrible menstrual pain. It can be used in endometriosis. It can be used in premenstrual dysphoric disorder or premenstrual depression. And yet, it's also true that some women will have major side effects, and we see it all the time. Right. There's some women that will have more depression on the pill. There's some women that will have hair loss on the pill. So it's really...
this is personalized medicine.
Yes.
It's not one size fits all ever.
So it's really, so to me, the pill is like, let's not get emotional about the pill. Like it's a great tool to have. Right. But it can have side effects,
for the
like
right
lots
person
of things.
At the right
Yes.
time, in the right
Exactly.
context. Okay, so last thing that I just want to dispel, if at all, or inform, is you can get a hormone test to assess for your fertility. Yeah. Truth or myth?
Well, that's a myth. I mean, and a lot of people talk about AMH, your AMH level.
Yeah.
And
tell us what what do they mean by that?
It's an anti-malarial hormone, so it's, maybe reflective of your ovulatory status in terms of like number of eggs that you have, So sometimes, infertility doctors had measure that, but, it fluctuates. So a one-time measurement cannot rule in or rule out, your ability to get pregnant.
Oh,
yeah.
I love that.
Yeah.
And speaking of PCOS, your AMH can actually be elevated in PCOS. It hasn't made it there as a diagnostic criteria for that, but we often see that, and it may or may not correlate quite with fertility in that aspect.
So, Anna, what about the corollary for perimenopause? Can I go to my doctor and ask them to run a magic test and tell me if I'm in perimenopause?
No,
What the heck, man? With all of our advancements, we can't tell when we're fertile. We can't tell when we're in perimenopause.
I mean, you can't. It's kind of like, what's the test for puberty? You know it when it's here, right? So right now we don't have a good test for perimenopause. Usually we assess it by, kind of symptom profile, what's happening. On the other hand, I do think that, medicine will advance. Yeah. And there are, just like we have continuous glucose monitors now, right, to measure your blood glucose, there are some tests that are in development for more kind of easier measurement of hormones. And there is a pattern that emerges in perimenopause. Your FSH, follicle-stimulating hormone, rises. Estrogen fluctuates, but over time it goes down. So I don't want to leave it at there is never going to be a test. We should never do hormone tests. Some people say that. Hormone testing can be useful in some situations, but there is not one single test for perimenopause.
I think that's a huge myth that is important to inform our listeners, the community about, right? Because you wish that there was such a thing, but it in reality doesn't exist as we speak today.
Yeah, and that's why I think it's so important, the educational component of this, really, to talk about symptoms of perimenopause means people are not even aware, of some of those symptoms, the sleeplessness, the change in appetite, things like that.
And it can backfire, right? Because and the conversation is changing now, but for decades, and even now, women would go to their doctor, including OBGYN, and say, oh, I'm experiencing this and that. Let's check hormones. Their hormones are a run, and that day, estrogen may be normal. So they are told, well, this is not perimenopause.
Well, the fluctuation point is the key, yeah.
You can definitely be in perimenopause and have, quote-unquote, normal hormone levels.
I can definitely see a wearable in the future for this, definitely,
yes.
right?
Yeah.
Tracking your levels and, for sure.
All right, so we have busted 10 myths today on this episode. What are your closing remarks for our listeners? What would you say is your one sort of pet peeve myth that you get day in and day out that you could almost just press, play on your voice to kind of tell your patients, nope, that's not true?
Well, I'm a high-risk obstetrician, so I deal with pregnant patients all the time. So for me, it's the myth that you can't eat sushi. I can't, I literally had a patient today.
I love that one.
Yeah, she was 37 weeks. She's going to deliver in a couple of weeks from now. And somehow we got talking about sushi, and she's like, I can't wait to have sushi after I deliver. Didn't I tell you at the beginning, our first conversation, that you can actually eat sushi? I say you don't limit the tuna because of the high mercury. You don't have the raw shellfish because of hepatitis risk. But there's a greater chance of getting sick from contaminated chicken than there is eating sushi.
So
that's
that.
a big one.
Oh, that's a great myth to be busted. And you, last one, Anna.
Oh, I have so many. And they change over time. My recent one is testosterone will solve all my problems. And testosterone, again, it's a useful tool. Lots of women feel better with it. There's a purpose to its use, but it's not a magic bullet. So, and I look at, at a lot of the tools we have as the anti-magic bullets. And that's probably my favorite kind of myth to bust. There is no such thing. This is personalized medicine. It takes time. It takes time to figure out what's right for somebody. And there's no single, potion, prescription, pill, cream that's going to solve all our problems.
Except pumpkin seeds and
Flaxseed, yes.
I love that. I am so grateful for this kind of opportunity. Honestly, this is sort of a dream come true because we are finally getting out of our silos. Here I am, a cardiologist speaking to two world-renowned OBGYNs with different areas of expertise within OBGYN. And I think the more crosstalk we have, the better women's health will get over time. Okay, so we've got requests to bust two more myths. One that is near and dear to my heart, quite literally. But we'll start with this one first. Truth or myth? Bras and the type of bras that you wear, underwire bras in particular, potentially can increase your risk of breast cancer.
Oh my God. No, that's really out there. So absolutely 100% not the case, right? Bras are there to support the breasts. They cannot induce, they cannot cause breast cancer in any way. Breast cancer is quite complex. There's genetic reasons behind it. There's environmental causes that increase the risk for breast cancer, a whole host of things. But definitely bras, whether they're underwire, whether they're made of cotton or whatever it is, cannot cause breast cancer.
Have you
What
gotten
Joanne
that one
said.
too?
Yeah.
Yes.
What she said. And the last one, heart disease, and this is, I'm answering my own question here, but heart disease affects men more than women in terms of being the number one killer.
Heart disease is the number one killer of women. So,
And
but you're the expert.
You're the,
so,
you're the
yes.
expert, right? We know that, women who have a heart attack will have a greater chance of dying in the first year than men after a heart attack, right?
They present later. They present in a more acute form because their symptoms often get ignored. And so they're presenting in more severe cases oftentimes, whether you look at run-of-the-mill myocardial infarction or heart attacks, or if they're in full-blown cardiogenic shock. You're anxious, don't worry about it, right? So, I'm not saying everybody's like that, but that's very frequent. And I think this historical, a man holding his chest, complaining
Shoveling
of,
snow,
exactly,
yes.
pain, radiating the jaw. We don't picture a woman like that. They may appear differently, they present differently, they have different symptoms. But yes, indeed, heart disease is the number one killer of women, which is also why it's so beautiful that we're talking like this, because most women see their OBGYNs as their everything, as their source of all health. And while OBGYNs do an incredible job, it's so important for us to partner across different specialties for women's health.
That's why collaboration, is key. And I do think that hopefully the time is coming where OBGYN, just like you said, we serve kind of in the front lines of women's health, and it should not be this bikini medicine. Right. OBGYN is whole person medicine, and it's so important to have the conversation, partner, and really look at people as whole people.
And just on top of that, it also works the other way. People that see their primary care doctor, maybe they're not seeing their gynecologist all the time. It's important for the primary care doctors, the internists, to understand all these conditions. They have to understand hormonal health. They need to understand, how complications of pregnancy can affect future cardiovascular disease and metabolic disease and things like that. So I think there needs to be, like you've said, several times, both of you, breakdown of these silos and much more communication and talking so that we really can fully take the best care of our patients.
And hopefully we're seeing that. We're certainly seeing that here. So exciting times.
Yeah.
That's it for this episode of HERology. I'm your regular co-host, Dr. Lala. For more groundbreaking conversations on women's health, subscribe to the Mount Sinai Health System's HERology podcast on YouTube Apple Podcasts, Spotify, or wherever you get your podcasts. HERology is a production of the Mount Sinai Health System and the Carolyn Rowan Center for Women's Health and Wellness. To learn more about the Rowan Center and our state-of-the-art facilities helping shape the future of women's health, scan the QR code on your screen or click the link in the description below.